Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk. I will try to make this a bit interactive. I'm going to ask everyone some polling questions. I'm going to take this opportunity to ask everyone for an update on your recent clinical experience with cabotegravir for PrEP and with long-acting cabotegravir rilpivirine for HIV treatment. You'll see the reason I ask you those things. And really my objective here is to review the most clinically relevant updates from the Adult and Adolescent Treatment Guidelines. There was an update at the end of September. I won't say it was the most dramatic update ever to the guidelines, but I do think there are some important points. So again, I tried to pick out what I thought was most clinically relevant. I don't have any conflicts or relationships to disclose. I will acknowledge our funders and do my best to avoid brand names. And again, let's start with a poll question. I'd like to just poll everyone and ask everyone's experience thus far with long-acting injectable cabotegravir for PrEP. So first I'll ask you about PrEP. Just in your practice or office, how many patients or clients are currently receiving it? I'm just very curious. And again, when we start talking about the guidelines updates, you'll see why. A lot of the updates relate to integrating long-acting PrEP and long-acting cabotegravir rilpivirine for treatment into clinical practice and considerations for individuals who have received those. So just please go ahead and weigh in, Adrian, whenever you feel like we have a decent amount of responses, please go ahead and share. So I think everyone should be able to see the results there. 76% no patients yet on long-acting cabotegravir for PrEP, 20% between 1 and 5, and 4% 6 to 10. Fantastic. So we do have some folks with experience with long-acting cab for PrEP. If there's anything you'd be willing to share after the talk about your experience thus far, I'd be very interested to hear it. And let me ask this related question. So one more poll, Adrian, please feel free to pull this up. How about individuals receiving long-acting cab rilpivirine for treatment? How many in your office or practice, whether you're a prescriber or not, patients or clients currently receiving the long-acting injectables? I decided to take this opportunity to poll the community, see where things are at, and then you'll see a lot of the guidelines updates relate to the long-acting agents. Okay, so about half with 0, about a third, 1 to 5, 8%, 6 to 10, 12%, more than 10 people on long-acting cab rilpivirine. Okay, so I think there's a lot of community experience here with these long-acting agents for treatment, and sounds like experience with cab for PrEP is growing. So again, once the talk is done, please feel free to share experience related to those long-acting agents. So again, the update to the guidelines had a number of potentially practice-changing points. A number of them relate to evaluating individuals who have received long-acting cab for PrEP or long-acting cab rilpivirine for treatment, and about how to integrate those into clinical practice. So one major point that the update calls out is that if a person has ever received long-acting cabotegravir for PrEP in the past and then is diagnosed with HIV, that is an indication for an integrase resistance assay. So 2 points here. An added indication for integrase genotype is any prior use of cabotegravir for PrEP. And then point number 2, they highlight that this is any past use, regardless of the amount of time since they last received a dosage of cabotegravir for PrEP. As we've talked about, this drug can last in the system for months to years. So this is an added indication. The guidelines still, for routine baseline resistance testing, only recommend RT and PR, standard genotype. They don't recommend integrase genotype at baseline for everyone, but they do make this point that if a person has ever received IM cabotegravir for PrEP, then that is an indication. They then go on to say that if a person has received IM-CAB for PrEP and they are diagnosed with HIV, that there is enough risk for integrase resistance that an integrase inhibitor-based regimen should not be started empirically. Meaning the two options for initiating ART in this scenario are either get your integrase genotype along with your standard RT and PR genotype, wait for the result, and then start an integrase inhibitor-based regimen, or while you wait for those results, start a boosted PI regimen, namely boosted darunavir with 2 NRTIs. So again, the point here being, if someone has received CAB for PrEP, they're diagnosed with HIV, you would not want to start an integrase inhibitor-based regimen empirically. You send the genotype. If the person is willing to start ART before the genotype results, you go with boosted darunavir while you await. So this has led to a small reorganization of the what to start tables. Really, it's less a reorganization as a retitling. It's still recommended initial regimens for most people with HIV, but now what the guidelines have is for people with no history of ever receiving cabotegravir for PrEP, and then a separate list for individuals who've received cabotegravir for PrEP. So this table, recommended regimens for most people with HIV with no history of cabotegravir for PrEP, is the table we've talked about before. You can see the recommended options, all of which are integrase inhibitor based, and most individuals in clinical practice will receive either bictegravir, tenofovir alafenamide, emtricitabine, or dolutegravir with tenofovir alafenamide, emtricitabine, or tenofovir DF, emtricitabine, depending on insurance status. The other options listed there, dolutegravir, bacavir, lamivudine, and dolutegravir, lamivudine, are not being used as commonly in clinical practice, but as we've talked about, are acceptable options in certain circumstances, noting the caveats there in gray for initial therapy. So then there's this new list of recommended regimens, initial regimens for individuals with a history of using cabotegravir for PrEP. Again, the recommended regimen before resistance test result is boosted darunavir with 2 NRTIs using one of the tenofovir-based options, pending your integrase genotype result, and then reasonable to switch to an integrase inhibitor. The other thing these guidelines have done, and I'll just touch on this briefly, is update the data on dolutegravir with neural tube defects. And really, these guidelines are now in line with the perinatal guidelines. They show that the updates from the study in Botswana demonstrate that the rate of neural tube defect with dolutegravir is not statistically different than with the non-dolutegravir based options. So dolutegravir is now again a recommended option for individuals of childbearing potential and recommended during pregnancy, with caveats about the importance of counseling and the importance of prescribing folic acid for individuals who may conceive. And these guidelines still recommend that if a person is trying to conceive, going to the perinatal guidelines and giving an option that is recommended during pregnancy. So I thought I'd update this based on the perinatal guidelines. We've reviewed this, so this is a bit of review, but I don't think that's terrible. The preferred options during pregnancy listed on the left. A reminder that TAF is now a preferred NRTI during pregnancy. You can see the recommended integrase inhibitors and the recommended boosted protease inhibitors, with the notes that raltegravir during pregnancy should be BID, as should boosted darunavir. You can see the alternative options, those still listed as having insufficient data or not recommended, with a reminder that the cobicistat boosted options are not recommended during pregnancy because of decreased levels in the second and third trimester. And both guidelines now have a note that if a person becomes pregnant while receiving injectable long-acting cabotegravir rilpivirine, they should switch to a recommended option. So cabotegravir rilpivirine listed as insufficient data for individuals who may conceive and not recommended during pregnancy given the lack of data. These tables have only been updated slightly, but I thought they were reasonable to review. So these are recommendations for viral load and CD4 monitoring, and then these inform a bit of the next recommendations, so I'll review this briefly. So after initiating ART, the recommendation for viral load monitoring now says within 4 to 8 weeks, then every 4 to 8 weeks until suppressed. The change here was it used to say within 2 to 8 weeks. I think 4 to 8 weeks makes sense. In clinical practice, we mostly try to do this at 4 weeks and every 4 weeks until suppressed. So that's a minor update. And then during the first 2 years of ART, these guidelines recommend monitoring every 3 months. After 2 years with a suppressed viral load, they say can extend to every 6 months. And they give the same recommendation after modifying or changing ART to recheck 4 to 8 weeks later. So that's the update within 4 to 8 weeks instead of 2 to 8 weeks. So a minor update, but I thought worth reviewing. And then I think this table is important as well. Reminders of how often they recommend CD4 monitoring. We really have backed off the frequency of CD4 monitoring over the years. And this gives a reminder of the recommendations that after initiating ART, the recommendation is to recheck 3 months later, not monthly like viral load. 3 months, really it takes longer for CD4 trajectories to change. And you can see here during the first 2 years of ART, the recommendation for every 3 months if the CD4 remains below 300, every 6 months if over 300, and then after 2 years of ART, assuming a suppressed viral load, every 6 months if remains under 300, every 12 months if between 300 and 500, and then listed officially as optional if over 500. So if someone's viral load is suppressed after a couple years of ART, they're doing great, their adherence is great, their CD4 count is high, really it is optional, and at most we might check every few years. And really in this scenario, I have a lot of patients who really ask and want to know, and I really try to steer them and educate them about the importance of viral load and steer them towards focusing on the viral load as the more important marker. The guidelines do mention after modifying ART due to virologic failure or recheck, or rechecking if there's any change in clinical status, if there are symptoms making you worried about an opportunistic infection, if someone's receiving chemotherapy or chronic systemic corticosteroids or something that could suppress some other situation that could suppress the immune system. I'll emphasize these definitions in the guidelines and then turn to what is a relatively important new emphasis in the guidelines. So this comes up in practice and on echo. So a reminder that the guidelines define optimal virologic suppression as a viral load below the lower limits of detection, whatever your lab uses. A viral blip is a low detectable, usually below 200, that then suppresses, and low-level viremia is persistent values below 200, as opposed to the situation of virologic failure, which is defined by a viral load above 200. And I think these definitions are important because viral blip and low-level viremia do not tend to lead to emergence of new resistance, whereas virologic failure does. And that has led to this new statement in the guidelines recommending drug resistance testing, basically genotype resistance testing, if the viral load rises to above 200. So that's a new change in this guidelines. They really used to say above 500. You can see here what I've put in this table is the strength of the recommendation varies by viral level, by the level of viral rebound. So strongest recommendation, obviously above 1,000, but then also strong between 500 and 1,000. But the guidelines do now recommend genotype if someone's viral load rebounds to 200 to 500. They give the acknowledgement or caveat that the lab may not be able to amplify virus and genotype may not be successful within this range, and that is true. But they do now recommend it, albeit with a relatively weak recommendation and low level of evidence. But that is a change that I wanted to highlight. These are also two new recommendations related to long-acting cabrolpivirine in the setting of suboptimal adherence. This one we reviewed a couple weeks ago. The panel recommends against long-acting cabrolpivirine for individuals with detectable viral loads or suboptimal adherence or ongoing challenges with retention and care, except in a clinical trial. That's a topic of a lot of discussion and controversy these days, and we may see updates in the future. And then they also make this note that whereas with oral ART, the ideal is to check resistance testing within 4 weeks of stoppage. That's always been in the guidelines as the ideal, because that's when you have the drug pressure and the genotypes become less sensitive over time after that amount of time has passed. They now have this point that, well, if someone has taken long-acting cabrolpivirine, regardless of the amount of time since last dosage or since drug discontinuation, genotypes are recommended, including integrase. So it's in parallel with the recommendation related to having any history of IM cabotegravir use for PrEP. And then finally, I wanted to note that the drug interaction tables have been updated. One change or addition is the addition of comments on interactions with the antivirals to treat monkeypox. Now, this data is limited. It's really not been studied. They acknowledge there's not a lot of data behind these recommendations. I've put here an example of the interactions between rilpivirine and tecovirimat that these guidelines call out. I will note that if you go to Liverpool and look at these interactions, the recommendations are slightly different. But if this comes up for you and is relevant, I want you to know that this table is available in the guidelines. It has been updated. Also would encourage you to look at other sources and talk with pharmacy colleagues because, again, there's not a lot of data. Tecovirimat is a weak CYP3A4 inducer, and rilpivirine is metabolized by CYP3A4, hence this concern about decreased rilpivirine concentrations. These guidelines really say that with oral rilpivirine, it's not clinically significant. The Liverpool site, if I remember right, says it may not be clinically significant, but you could consider doubling the dose of oral rilpivirine from 25 to 50 milligrams during tecovirimat and for the 2 weeks after. It's really a weak recommendation to consider. And then for IM rilpivirine, these guidelines say do not initiate IM rilpivirine within 2 weeks of tecovirimat treatment. Again, that's because of the potential to decrease rilpivirine levels, and those levels early on in IM rilpivirine therapy are so important. Other resources say if someone's just started IM rilpivirine and needs tecovirimat, consider adding 25 milligrams a day of rilpivirine during tecovirimat therapy. Again, these are pretty weak recommendations, and at the level of, if you're concerned about someone's, maybe missed doses of rilpivirine or low antiretroviral load on rilpivirine or something like that, and you feel like an added dosage will be important, then consider it. There are a few other notes to consider in these updated tables about potential interactions with brincidofovir and cidofovir, but since those aren't used very much in clinical practice, I just wanted to note this. But if you're seeing someone with monkeypox, considering prescribing tecovirimat or another antiviral, these tables and guidelines have been updated, and there are other resources out there to look at. And I'd be curious from pharmacy colleagues if you've seen this come up and if you have recommended changes to the rilpivirine or other dosages or not. With that, I will close. I do want to note at the bottom where you can find these guidelines, and then I do want to make a quick note about how to see what is new. They do have a summary of what's new. I found it, especially in this update, to be rather confusing and difficult to tell in some of the sections what was new. And then David Spock actually reminded me that if you download the full PDF, you have to download the full PDF of the guidelines, then you can see the highlighted text of what is new. And that actually was easier. So if you want to get more detail here, one thing you could consider is download the PDF and just scroll through the highlighted portions, and that will call out for you the new additions and changes. But I will close there and would love to hear questions or comments.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button, and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.